Yeah.
Yeah, let's say it now. SKJ.
No, you will be the one to say it. Is GM featuring?
No, not.
Thank you so much for joining. You're welcome. So it's 1 minute past 2, and I think we can get started. So as you're joining us, just keep saying hello to us in the chat room. We can see you. Hi, Agoro. You're welcome. So I'll just give you a brief opening remark of what we're here about, so that for those of you who don't have an idea what we do here, probably you got an invitation from a friend, or you stumbled on some of our adverts on Facebook. I'll just give you a brief introduction of what we do and what we're all about, so that you get familiar and feel at home. So the Pistis Foundation is a registered non-for-profit organization established to be a model provider for empowerment opportunities for the economically challenged in our target communities. We drive our objectives through education, health, and shelter intervention programs as our key focus areas. So one of our key focus areas is actually health, and that's why we're here. Under the health, Pistis Foundation launched one of its flagship programs known as the UBOMI in March 2019. UBOMI is actually an annual free mega medical and surgical outreach that caters to between 3,500 to 5,000 beneficiaries within a 1-week period in a target community. This outreach hosts at least 100 registered volunteers, that's healthcare professionals, and about 150 volunteers, non-healthcare professionals, rendering free medical and surgical services to individuals with eye and dental cases, gynecological services to general medicine, obstetrics, and general surgery. Now, this webinar is also one of the initiatives of Pistis Foundation Health. It's a health awareness webinar, and we hold this quarterly to address diseases and medical conditions that are prevalent in this part of the world. So for today, we're going to be talking about hernias, and we have 2 experts in the house who will be taking us on all we need to know about hernias. So usually we engage professionals who enlighten us and empower us to make decisions that keep us healthy. So thank you so much for joining in once again. I hope, can you also see me? Up NEPA.
Yes, we can see you.
Thank you so much again for joining in. I hope now that you're aware of what we're here for. So for today, we have 2 moderators. I will introduce myself. I'm one of the moderators, and we have another moderator in the house. Hi, SKJ. My name is Chineye Rajaf. I'm a pharmacist, and I'll be moderating moderating this event today. And join my colleague too, SKJ. Please, could you introduce yourself?
Good morning, everyone. Good afternoon, everyone. It's such a great day, such a good time as this to have our webinar one more time. Thanks so much, everyone, for joining. We don't take this for granted. You're very welcome.
Okay, so we have 2 experts in the house who will be talking to us about hernias. So in the next few minutes, SKJ will introduce the first speaker, and then we'll have him come up to give us the first initial segment of this webinar. Thank you so much, SKJ.
All right, thank you very much, Nate. Well done. Great to have everyone on board. I'm glad it's a day fixed, and today is the day. Especially, we're talking about a very, very important topic today. Thanks so much for tuning in, everyone connecting. I can see quite a number of people from different locations. Oh, please kindly share in the text, in the chat section. Let's know where you're connecting from. Let's know where you're connecting from. Okay. You're connecting from Lagos, Nigeria, from UK, from US. Wherever you're connecting from, kindly type in the comment section. Let's know where you're connecting from. We know this is a global world right now, and everyone is free to just connect from wherever they are. Thanks so much, Lagos, Nigeria. I'm also connecting from Lagos, Nigeria. Well done, great. Dr. Babs, I'm sure you're connecting from Eket. Thanks so much. Thank you, thank you, thank you. Wow. Can I see in the comment section where you're connecting from? Inem Sam, thanks so much, Lagos, Nigeria. Okay, today we're going to be talking about hernia. And I'm sure we all know that this is a very, very serious issue, especially in our country. In the states where we are, we've seen quite a lot of statistics of what this has brought to us at this moment in time. And we have decided to pick it up as a topic to discuss and enlighten ourselves majorly about what this hernia is all about, and to demystify what is all around it that we don't know about, and some information for no reason where we can't just pick from anywhere, to just confirm whether it's actually true or not. So today we have Dr. Babs and also Dr. Oppa, who will be sharing with us and will be enlightening us on what hernia is all about, as you can see our topic. So firstly, we're going to have Dr. Babs. Permit me, I crave your indulgence. I call him Dr. Babs. He's not the regular doctor, So today, I'm having Dr. Babatunde Joseph Adekunle. So Dr. Babs, I'll introduce as is being called fondly Dr. Babs, in quotes. By most people, is a friendly, jovial, not your regular doctor, as I've said, every kind of doctor, your regular, everyday kind of doctor. So I'll advise you to sit back and fasten your seatbelt, to let's have a good time together. I'm sure we're all excited. So Dr. Babs attended the premier university in Nigeria, the University of Ibadan, from where he graduated over 20 years ago. He proceeded to have his master's in public health in the same institution, and fellowship in public health medicine from the University College Hospital, Ibadan. He has worked with local, state, national, and international organizations in Nigeria. Has also worked with private organizations like Zenith Bank Group before joining ExxonMobil in Nigeria. He's currently the occupational health manager in charge of ExxonMobil onshore clinics in Lagos, Akwa Ibom, and Rivers States. He has been happily married to our fantastic sister, Miss Ariola, for about 18 years. And the union is blessed with 2 adorable young men. So ladies and gentlemen, without much ado, welcome with me Dr. Babs, as I've said earlier. In the comment section, can I see your applause? Say, welcome, Dr. Babs. Welcome, Dr. Babs. Welcome, Dr. Let's welcome Dr. Babs. Ladies and gentlemen, I can see in the comment section, I need us to welcome Dr. Babs. We have people all the way from Akwa Ibom. Yeah, applause, applause. Let's welcome Dr. Babs. So, Dr. Babs, you have the floor. You're welcome, sir.
All right, thank you very much, SKJ. I call him SKJ too, but it's actually Stanley Kumuli Johnson. So thank you, SKJ. All right, and thank you for that introduction. Well, you're making my head to swell. All right, I'll just go straight to what we're discussing today. I assume everybody can see my screen clearly. So today we're going to be talking about hernias. We're going to be looking at definition. We're going to be looking at types and causes. And then I have another colleague, Dr. Para, that will be taking it up from there. He's a surgeon, and then he'll be talking to us about the treatment of hernias. So what are hernias, and what are the types that we have, and what actually causes herniation? So I have different ways of defining it and making it clearer to us for the people that may not be medically inclined. So generally, when you talk about herniation, we are talking about the bulging of an organ or tissue through an opening that is not a normal opening, an opening that is not expected to be there or is not supposed to be there. So that occurs when you have an internal organ or any parts of the internal structure of the body protruding through the wall of a muscle or a tissue that normally should contain it. So what that means is normally the tissue or organ is contained in that particular thing, but it's able to protrude through the wall. So that means it's not supposed to be out, but it's protruding through that wall. And that's where you have the word herniation coined from. So this happens when internal organ pushes through weak spots. Okay, it's able to push through that wall of the muscle because that spot is weak. Okay, or it's been weakened by anything, maybe congenital or maybe iatrogenic, but something has made that part of the muscle or that part of the tissue to be weak. And of course, you see this mostly in the abdominal cavity. Why the abdominal cavity mostly? Because that's where you have different organs, you have multiple organs. When you look at the parts of the body, the head is rigid, neck rigid, mostly. The legs, the arms, they are rigid. You actually don't have floating organs, that can pass through anything, except when you have a fracture and then the bone comes out through the skin. So herniation occurs mostly in the abdominal cavity. That's why you have intestines, different visceral organs, and then you have maybe fats, and all that can actually cause that protrusion. So what are the types of hernias that we have? The commonest of them will be inguinal hernia, okay, plus or minus scrotal. And why do I say that? Inguinal, it can be inguinal, it can be inguinoscrotal. So when do you say inguinal hernia? Inguinal hernia, when you have things from the abdomen, actually going from the abdomen into the upper part of the pelvis, then it goes, comes out through, the herniation happens around the groin, vessel or tissue or organ from the abdomen coming through the groin, pushing the skin of the groin out. I may be dangling men, or may not be dangling like what we see in most women. But sometimes it actually goes into the scrotum in men. Then you just see that the scrotum is hanging, is bigger than what is expected. That's why you call it inguinoscrotal. Umbilical hernias are also the hernias that you see usually around the umbilicus. Okay, that's the navel. So these ones are usually, you see them centrally. Okay, can be just around or can be through the umbilicus. So, and that is usually due to a deficiency in the anterior abdominal wall. That's when you call it umbilical, because it's related to the umbilicus. The epigastric hernia, for people that don't know the epigastrium, that is just the space just below the chest cavity, just at the beginning of the abdomen, somewhere right here. When people say they have earthborn, that place that they usually point to, that's why you have the epigastrium. So you can actually have an organ, okay, pushing through that part of the abdomen. So you see that the names of hernias are actually descriptive, okay? They describe where they occur or how they occur. So that's epigastric hernia. Femoral hernias are also the next common hernias. So you see that, the femur is the thigh bone, that's the femur. So you have a tissue that's protruded through the abdomen and is going even beyond the inguinal crease and is going on top of the upper part of the femur, of the thigh. So that's what we call the femoral hernias. Those ones are usually more common in women. So the hiatal hernia is the next common hernia. And the hiatal hernia, actually, you can't see it from outside. It's like, you have a muscle that's called the diaphragm that separates the chest from the abdomen. So the diaphragm is like an umbrella, above the abdomen, and then you have the chest cavity on top of it. But we all know that the esophagus goes from the mouth to the nose, through the chest and into the abdomen to join the stomach. So even though there is a covering, that is separating the chest from the abdomen, you have that diaphragm, and you have the esophagus passing through the diaphragm. So that means there's already an opening, okay, between the chest and the abdomen. And so that opening, you can have the stomach actually protruding through that opening to go into the chest cavity. And of course, you can't see that physically outside. So that's the one we'll call the hiatal hernia. Incisional hernia are the ones that I know many people may have seen or noticed before. You have a surgery, and then that part of the surgery part does not heal totally, or there's an infection, or the healing was not complete, or the suturing is a bit weak. And so you have that part of the body that's actually not as strong as it should have been. So those incisional hernia, you see them usually after surgery. And you see them even more commonly in people that may be overweight, or maybe they've had chronic cough, or they have maybe wound infection after the surgery. So you have some weakness in that muscle. So then you can have organs, pushing through that. And a little bit about the umbilical hernia. You actually also see that more commonly in people that are overweight, or maybe in pregnancy. In pregnancy, there's naturally an increase in the pressure in the abdomen because of the uterus carrying the baby that's getting bigger and bigger and bigger. So because of that, you have pressure on the anterior abdominal wall. So you can actually have that occur even more. All right, so sometimes some people have some conditions or diseases that makes them to have increased abdominal pressure, maybe like people that have fluid accumulating in the abdomen. So those ones also, they can be more predisposed, or even some men that have BPH, the prostate is getting bigger, okay? And so urine is accumulating more in the bladder. It's naturally increasing both the pressure in the abdomen and of course in the pelvis. So you can have them predisposed to that. And people that have chronic constipation actually can also increase abdominal pressure and then increase the risk of hernias. So what are the commonest hernias? Inguinal hernia, like I said, the tissue from the abdomen, most of the time is the intestine, going through into the inguinal area and then protruding out there. And like I said, you see that more commonly in men than women. And the femoral is more common in women than in men. So both of them, you can see this diagram, both of them are actually very similar. Okay, it's just where they come out to that makes a difference. The inguinal hernia stops around that inguinal crease, okay, but the femoral hernia goes further down into the upper part of the thigh. And you can see the umbilical hernia. A lot of people will say, oh, I have an outie, I have an innie. A lot of times, it's actually an umbilical hernia, okay, that they have, especially the outies, okay? So you see it's big, bulging, and it increases sometimes, it reduces in size sometimes, then you know that this person most likely has an umbilical hernia. The other one that I just wanted to also see, because a lot of people have these conditions and they don't know because they are not able to see it physically, and also because they have symptoms and the doctors continue to treat them for ulcer. They say, oh, you have PUD, peptic ulcer disease, and they continue to take medications. They don't do any investigation. They don't even know what is causing the unresolving symptoms of ulcer. So if you look at this is one of the types of hiatal hernia. Hiatal hernia, there are three types. You can have the sliding, you can have the paraesophageal, and then you can have the mixed type. But this particular type, the sliding hernia, for example, if you look at up here, this is the normal esophageal sphincter that does not allow food to go back into the esophagus. But you can see that here, this sphincter is supposed to be at the level of the diaphragm, but you can see that it has slid into the chest cavity, okay, from the abdomen. And so you already have contents of the stomach going up into the esophagus from here. So someone like this will continue to have heartburns, will continue to have symptoms, and they will continue to take medications and it will not resolve. And then the doctor is not good, or the medicine is not good, or it is something else that's causing it. And this is usually misdiagnosed. So it's just for you to be aware of this, so that if you have someone or you have unresolving symptoms of PUD, then you might as well have to go to the doctor and maybe get some scan done and get some further investigation done to be able to make a good diagnosis. So when you have all these hernias, what do you do? Do you even need to do anything? Okay, or do you need to just allow it be, and just move on with your life? That would depend on multiple things. Do you have any serious symptoms? For some people, beginner hernia, they want to wear a bikini, they want to go to the beach, or the man is into sports, he bends over a lot, or is a gym instructor, or someone that likes to wear tight things, very muscular, for cosmetic reasons, because it just does not look good. Okay, so you have an outie, you have an umbilical hernia, and of course, when you wear your tight-fitting clothes, it's abdomen. So people like that may want to operate it just for cosmetic reasons because it doesn't look good. But importantly, in medicine, we operate hernias because of symptoms. Okay, what are the possible symptoms you can have when you have an hernia? The first thing you will see is a sign that it is bulging, there is a swelling, there is a bulge. That's the first thing you will see. The next thing you may see is pain. Remember that this tissue or organ is passing through a tight space, to push out. So it can get stuck in that small hole. And of course, that will cause pain. Okay? That herniation can cause pain, can cause an infection, can actually lead to that herniated part of the tissue to become gangrenous, which then becomes an emergency. So if you have symptoms that are unresolving, then you may want to operate. And of course, for cosmetic reasons, like I said, you may want to operate. So here, I'll just hand over to my colleague, Dr. Oppa, to take us into the different types of treatments and other things about hernia. Thank you.
Thank you so much.
Thank you very much. Okay, so I would like to introduce Dr. Oppa officially before he takes over. So if you don't mind, Dr. Oppa, please let me introduce you properly. Thank you everyone for joining in once again. My name is Chinera Jaffa. If you didn't join in the beginning, I'm one of the moderators, and I have another moderator in the house, SKJ, and Brother Stanley. Say hi, Brother Stanley. Okay, so let me quickly introduce Dr. Oppa before he takes over. So Dr. Chimrima Augustine Oppa, he hails from Obazu. Hey, sorry, please excuse my Obazu Ndieri in Imo State, born to Walter and Veronica Oppa 43 years ago. He finished from the University Primary School, Sokoto, also attended Federal Government College, Sokoto, and also Usman Danfodio University, Sokoto. The journey to become a plastic surgeon began in 2005 in Sokoto, as we all know, as we all can see. It took him to Enugu, Ibadan, and Accra in Ghana. He was certified by the West African College of Surgeons in 2013. Some of his experience include consultant plastic surgeon in UDU, that's Usman Danfodio University Hospital, in 2012 to 2015. He was also a lecturer at UDU Sokoto 2 from 2013 to 2019, and then now a plastic surgeon at FMC Owerri from January 2020 till date. His current life roles include he's a youth pastor in his local assembly, that's Winners Chapel, Port Harcourt Road, Owerri. He's a husband to Oluwamayowa Opara. He's a father of 2 young men. He's a volunteer on the medical outreach with Pistis Foundation and PHI. And also he is a lead service provider with Beyond Vanity PSS. His interests and hobbies include reading and farming. Interesting. So Dr. Oppa, you're welcome. And I have formally introduced you, and we actually want to, you'll be continuing from where Dr. Babs left off to talk about some surgeries and medical treatment outcomes for patients or people who have been diagnosed with hernias. So please let's listen and drop our questions in the chat room. Thank you so much.
Thank you. Thank you so much. First, I want to thank Dr. Babs Adekunle. He's done a very great job of introducing hernias, and he has brought us up to speed. I believe in a language that we can all understand. Here I have an illustration of exactly what he was saying. He described it so perfectly, and but this is the picture illustration. You can see that there's a tiny, I need us to see the pictures so that we can move along as I'm talking. You see that ring here is the hole through which the internal organs are pushed through to the outside of the cavity, and we technically call that a defect. And the tissue that has been protruded, one of the reasons he tried to explain to us that because of symptoms and for cosmetic reasons, surgery is indicated. There's also a third indication, that's complications. He described when the blood supply has been interrupted, and we call that strangulation. Technically, that's then the other reason why we operate, that is for complications, is when the contents of the intestine can no longer pass through. So the part that is herniated serves like a blind end, and we call that intestinal obstruction. So those are two additional reasons why we want to operate. In these two instances that I've talked about, it's actually an emergency. Let me just backtrack a little bit that in the past, with regards to history, the first or the earliest written proof of patients that have suffered hernias and even the surgical procedures that were undertaken to treat them dating back to ancient Egypt and as early as 1550 years before Christ. Now, the current breakthroughs that we enjoy in surgical care happened about the 19th century, the 20th century, and 21st century. In the 19th century, there was an increased understanding of what a hernia was because scientists and anatomists were now able to exhume bodies and even have bodies that we use as cadavers today. It's regular practice today in medical schools for medical students to be trained with cadavers. Cadavers are basically bodies of people that have passed on, and we dissect it to have an understanding of what the living, what we encounter in the living normal, and then in pathology we do the abnormal conditions. So that understanding has helped the practice of surgeons in hernia. And then in the 20th century, when anesthesia broke through with being able to put people to sleep, and then infection control, the practice and the cure, the treatment of hernias improved dramatically. So the current body of knowledge that we have is what we are using to manage hernias today. Dr. Babs did a very great job. So I'll pick up from management. So the management of a hernia involves non-surgical or pre-surgical, and then the surgical procedure. Before we take on the treatment of a hernia, we first of all want to establish a diagnosis, and it follows the whole procedure in every other part of medicine. We first of all sit the patient down and ask the patient specific questions. Some of those questions are like, when was the first time you observed this hernia? Do you have any associated disease conditions? Technical term, we call that comorbidities, but disease conditions like diabetes, hypertension, any bleeding disorders, sickle cell, these tend to have special procedures that we have to do, special precautions that must be taken. And then we want to know if this patient is coughing, because cough is a very significant both causative factor primarily and a secondary causative factor, that's increased incidence of recurrence after the hernia is repaired. If the patient is coughing, there's a chance that the hernia is going to happen again. So all these things are established in the history. During the physical examination, we want to make sure that it is a straightforward, uncomplicated hernia. There are certain instances where a patient can come with a complicated hernia, and I'll paint a picture. Prostatic enlargement is a very common condition amongst men, both the benign prostatic hyperplasia and prostate cancer. At the end of the spectrum of the natural history of prostatic enlargement, some men can actually go into retention, meaning that they can't pass urine as freely as they used to. So that involves some degree of straining. That straining can produce a hernia. So these are the things that we're looking out for in physical examination to be able to treat the patient as a comprehensive, complete human being, not just that he's a hernia that we're dealing with, but we're dealing with a human being, and what other problems the patient has can also be isolated. Now, Dr. Babs talked about internal hernias like the hiatus hernia that cannot be seen by physical examination. This is where imaging comes in. The most helpful imaging that we have in our own environment is the ultrasound, because it's cheap and can be used by almost anybody. But the other ones, the high-end ones, include the CT scan and the MRI, where they are available and where they are affordable to the patients. They are also used to detect the presence of internal hernias. Now, in preparation for surgery, we also want to do some investigations just to determine that this patient is fit for surgery, is fit for anesthesia, and that the wound that we're creating in the process of trying to repair the hernia will heal without complications. And these tests include a full blood count, electrolytes, urea, creatinine, retroviral screening, fasting blood sugar to screen out for diabetes, and then clotting profile to make sure that during the surgery, abnormal bleeding does not happen. Now, let's start with prevention. The prevention of hernias involves maintaining an ideal body weight, both by dietary inputs and exercise. Now, the dietary inputs would encourage, in addition to a balanced diet, that we all have a high input of fruits, vegetables, and whole grain to avoid constipation. Constipation is one of the things that makes people to strain, and this straining increases the chances that a hernia will develop. We also need to avoid lifting heavy weights beyond our own capacity. Each of us knows our own capacity. I mean, you can't ask me to pick a bag of cement and I'll do it. It's beyond my capacity. But I can carry a bucket of water comfortably. And even in carrying a bucket of water, we should position ourselves properly for weight lifting. There's a correct positioning for everything that you're going to carry. I'm sure we've watched weightlifters once in a while. You see, they have this belly abdominal binder. They squat before they lift the weight, and then they pick it up. So the closer whatever you're lifting is to the center of gravity of your body, the proper it is for the body, and then we avoid hernias. But improper positioning makes us to strain excessively. Now, anyone that has persistent cough or persistent sneezing needs to see a doctor ASAP, so that the condition causing that cough and sneezing can be taken care of before the abdominal walls and the tissues get weakened. Now, it's also very, very important to avoid smoking. Why and how does smoking affect the tissues? Smoking is associated with persistent cough, chronic cough in some instances. And this chronic coughing is one of the predisposing factors to hernia. Secondly, smoking reduces the immunity of the individual and triggers off some molecular reactions leading to weakening of muscles and tissue planes where these hernias are known to protrude from. So what are the treatment options? Like Dr. Babs mentioned rightly, surgery is the only treatment option for a hernia. But in my practice, I've come to discover that not every family can afford surgery, especially on the outreaches that I've been to. I've seen families that can barely afford a hernia. So what options do they have? I mean, if they can't afford surgery, what next? The first option is watchful waiting. By watchful waiting, we mean you educate these patients or these people that have hernias and tell them that it's true, you have a hernia. It's true, you may not have enough money to afford a surgical procedure, but while you are preparing for this surgical procedure, you need to pay attention to symptoms like pain and reducibility. Reducibility refers to that instance or that character of a hernia to disappear sometimes and reappear. By the time a hernia no longer disappears, it's time for you to go see the doctor to find out what's happening. Secondly, by the time a hernia starts becoming painful, you have to go and see your doctor to find out what's happening. It might be an emergency that is working on. And then other symptoms like vomiting, constipation may actually be attributed to the hernia. So this is watchful waiting. We are waiting for the patient to be able to afford the surgery, yes, but at the same time, they know that there are complications and symptoms which, if happen, it cuts short the waiting period. Then secondly, some people have advocated the use of abdominal binders, but it has to be used with caution. The defect, I showed you the defect earlier, that is the hole through which the internal organs are being pushed out, has to be wide. If it is wide, then you can comfortably use a binder. But if it is very narrow, a binder is not advised because it can apply undue pressure and result in strangulation. So let's talk about surgery. The surgical options include open surgery, laparoscopic or minimal access surgery, and then robotics surgery. Before I explain each one of them, I would like to just talk about the aim of surgery. The aim of each surgery is to return the patient's abdomen back to the normal anatomic and functional state. At the same time, the techniques are focusing on reducing the recurrence rates. One of the biggest complications with hernias is the recurrence of that hernia. Now, depending on the age, open surgery can be a herniatomy. A herniatomy is most performed in children below the age of 5. And it's a surgery that is performed on inguinal hernias or inguinoscrotal hernias. All we do is that we take away the hernia sac. We just remove the hernia sac. Now, because children heal very, very fast and they don't have any inherent weakness, the hole through which the hernia sac is that tissue that contains the organs that are protruded. So the muscles and the tissue heal so well that there is no longer a defect for organs to protrude through. That's what a herniatomy is. A herniorrhaphy, on the other hand, after the hernia sac has been removed, now that hole is repaired with the patient's own tissue. If it is muscles that are lying around, example, the inguinal hernia, we use the rectus abdominis sheets and then the conjoint tendons, the anatomical structures around that place, and then we just close that hole such that it is only the spermatic cord that passes through in men. And if we're repairing an inguinal hernia in women, we close the hole completely so that nothing can pass through. Now, a hernioplasty, on the other hand, refers to using materials like meshes. They are not part of the patient's own body, but they are synthetically produced. And sometimes we can also get them from the patient's own body, a distant part. That is, maybe we're using a fibrous sheet from the thigh to repair a hernia in the abdomen. So those are examples of hernioplasty. In other words, we're not using tissue that is around the defect to repair the hernia defect. Now, so open surgeries have the advantage that you have unlimited access. In other words, you can open as wide as you can manipulate the tissue as much as you can. The shortcomings for open surgery is that the scar is usually very, very obvious. And sometimes there is the incidence of infection, there can be delayed wound healing. Now, the minimal access surgery, on the other hand, you go through like a stab incision. And the advantage of that is that the scars are usually hidden. And then the downtime for the patient is usually very, very short. Patient that comes into the hospital 8 a.m. in the morning can actually be discharged by 6 p.m. in the evening if someone who is conversant with minimal access surgery undertakes the surgery. So the question is, why isn't minimal access surgery very commonly offered in our own environment? Number one, it's more expensive to set up. It has a tower. Number two, the learning curve is very high. It's not every surgeon that has the privilege in Nigeria, for example, or Africa. It's not every surgeon that has the privilege of going through the training for minimal access surgery. For those of us in this generation, it's very similar to playing a Nintendo game. So you are manipulating instruments on your tower and you're looking into a screen for feedback, as opposed to open surgery where it's like, okay, let me describe it this way. Open surgery is like eating amala with your fingers. It's very easy. You can manipulate it anyhow you want to manipulate it. But laparoscopic or minimal access surgery is like eating amala with cutlery. you are using something to manipulate the tissue, and the only feedback you have is the screen. Now, robotic surgery is even more delicate. It's the use of robotic devices. It's more complicated, but the results are very, very similar to minimal access surgery. It's being used in some places with a huge success. Now, there is a conversion rate. Some people can start the surgery minimal access and they have to convert it because they have encountered problems one way or the other. So what are the expectations for a hernia surgery? An uncomplicated hernia surgery, the hospital duration should not, admission should not be more than 3 days. It should heal in an uncomplicated, timely way. We don't expect that the hernia should recur, but if there are associated conditions like diabetes, it may take a little bit longer. If the patient has cough, there may be recurrence, and that's why we tend to isolate these instances and treat them properly. Now, in the post-operative period, that's after surgery, what are we looking forward to? First, wound care. Most surgeons will inspect their wounds for the first time after 5 days, if it's properly dressed, and then every 2 days thereafter. An abdominal wound should have healed completely, that is to become watertight in 2 weeks maximum. And after 2 weeks, you don't have to dress it again. You don't have to cover it with plaster or gauze at all. What medications are you going to be taking? In Africa, because our environments are not as clean as in the Western world, we tend to prescribe antibiotics for a longer period. In Europe and America, sometimes hernia surgeries may not have, hernia patients that have had surgeries may not have antibiotics prescribed, but we don't do that in this part of the world. And it's because our infection rates are very high. Apart from antibiotics, we also give painkillers, and we balance painkillers. We no longer give just one drug, and then sometimes the patient says, I don't like it because of the side effects. We give a combination. We use minimal doses. So sometimes we use some things as simple as paracetamol. We can also use tramadol. We use non-steroidal anti-inflammatory drugs like aspirin, but aspirin is the lowest grade. We tend to use diclofenac and ibuprofen. Just a little of everything so that the patient has, at best, a minimal discomfort. And at worst, it's just a breakthrough pain. And what is breakthrough pain? A breakthrough pain is a patient that has been pain-free, then all of a sudden maybe coughs or sneezes or has to go wee or poo, and then there now is a sharp pain. So that's the worst thing that should happen. Anything that is beyond that, you have to call back your doctor to tell him that the pain medication is not working properly. There will also be dietary modifications in the first 6 weeks. And the objective of those dietary modifications is to ensure that the patient who has had surgery does not experience any form of constipation or diarrhea, because constipation and diarrhea tend to make the patient strain, and straining increases the recurrence rate of hernias. We also want the patient to avoid physical straining. Specific terms, we don't want you to carry weights, no carrying of buckets. Try to avoid climbing stairs if that's a strenuous activity. And for those that are married, we want to give our partners like a break, at least for the first 6 weeks to 3 months. During that period, the recovery of the tissues that have been repaired is very, very fast, and you don't want it to be interrupted. In the long term, we'll also want individuals that have had this hernia surgeries to avoid weight gain and to quit smoking if possible. The objective for all these instructions is uncomplicated and timely wound healing to avoid recurrence, and so that the patient experiences bearable pain at the minimum. In conclusion, hernias are relatively common conditions. We've tried to talk about how they can be managed in individuals that can't afford it, because in our society, we do have them. But when you can't afford it, it's best to just go for surgery, get rid of the hernia, and then you have your normal life back. Surgery, unfortunately, for many people who don't like to hear that word, surgery and operation, has been the only treatment modality for a very, very long time. And it's both safe and available in our environment. Thank you very much.
Thank you so much, Dr. Kwara. Thank you so much. In fact, one thing I love about these sessions is that you have brought medicine home to us and you made it easy for us to understand. Gone are the days when doctors used to, be secretive about how they do their thing, and just code everything. Now it's made it so simple and it's really, really easy for us to understand. I hope we're all getting the flow of everything. So now you understand why you have medication. If you've been to a surgery, if you've had a family member ever done a surgery, now you understand why all those medications are given to them post-surgery, and you understand why some medications are even given to them before the surgery. And then you understand some of the things that go into decisions, objectives of the surgery. So you should now, at least you have an idea of what the doctor thinks about before he thinks about surgery. Because most times people are scared of surgery, especially in this part of the world. There's an extra prayer that goes into surgeries, When a family member is going for a surgery, there's an extra prayer, you have to do like 3 days prayer and fasting. It's very important. So I can imagine the fear when people hear surgery. It's not like we in the healthcare in professionals, the healthcare people, that we just talk about surgeries like, okay, it's just one of those things. It's actually we're thinking about it in terms of outcomes, in terms of objectives. Most of the people are thinking about it in a very fearful manner. So it would actually lead me to my first question. So we're going into the session where we have a couple of questions that we'll ask you, and it will be as interactive as possible. So the first question is about what your advice, generally. I think I'll just throw it to you, Dr. Kwara, since you're talking about surgeries. Your advice. So I used to have a driver who had hernia. I had no idea what hernia was initially until I realized that he was always in pain. Once in a while he would go to the corner, especially when we park, because I was on the field. I was a sales professional, so I was on the field. So whenever we have to park somewhere, he would go to a corner and he would be, in pain. He used to smoke. So I used to fight him for the smoking, but I didn't understand that there was a pain behind the smoking that was making him smoke. Maybe he was trying to relieve the pain. I didn't know what he was doing. But later, eventually, I realized he had hernia. And in fact, then the surgery wasn't so expensive. I remember referring him to General Hospital at one of General Hospitals to go, and we found out that it wasn't going to cost him about maybe 25 to 30,000 naira to do the surgery, but he was scared. So that's where I'm coming to that. What do you advise someone who is scared? Someone who feels like everybody around them is telling them, their family members are telling them, if it's not killing you, don't worry, leave it. Maybe it's just small pain, just come and it will go. Just endure the pain for that while when it comes, and when it goes, it goes. What's your advice to someone like that? How do you advise someone who is scared of going into a surgery for a hernia? Dr. Kwara.
Okay, so I'll approach it from two angles. The first angle is most people are scared because they either don't understand the process, or they have heard stories of people who have gone for surgeries and came out with complications, and the worst complication that can happen is death. So to overcome that aspect of the fear, the doctor has a major role to play. The doctor has to demystify the process of surgery. If it's possible, take the patient on a tour to the theater, have one or two patients who have gone through the surgery and it was successful, talk to this patient, this client. And then the other thing to do is to explain in details the surgical procedure and the healing process. I've discovered in my practice that this helps a lot of people to overcome the fear. Now, the other angle to fear is the dimension of the fear of the unknown. And for that angle, I think that people should, before they come to seek a doctor, pray and put everything in God's hands and trust that God is ordering their steps to this particular doctor to solve their problems. I think on these two platforms that most people's fear will be addressed. Any other thing is actually a specific issue, and I believe communication would help us to overcome that.
Thank you so much, Dr. Paya. Thank you so much for handling that effectively. So if you have any other questions, please, we would like you to drop your questions in the chat room. There's a section for question and answer, and we'll take it after this interactive session. So Dr. Babs, I want to ask you a question. And it's more of, let me see. Let's see, is it spiritual, this hernia thing? I know that, yes, we've handled the fearful part, but where does it come from? Like, is it genetic? Is it spiritual? Are people after me? Is it my village people that sent it? So please, people are asking, people are wondering, where did it come from? Where does it really come from? Does it just happen for no reason? Did I commit a sin? Please help us, Dr. Babs.
You know, it's you're actually asking the questions that a lot of people ask, you know, especially when you go out for community programs. Hernias spiritual? No. Hernias are not spiritual. Hernias are common medical conditions that God has given us wisdom and enough knowledge to be able to treat. So they are natural defects. They happen, okay? And like we said, some people have that defect. They are born with the defect that makes the hernia to happen. So you can say they don't have a choice about it. Okay, but for some people, it is caused by different things. But hernias are not spiritual. They are pretty physical and they can be treated very easily. You know, like Dr. Opara has taken us through all the ways that can be managed. So hernias are not spiritual. Okay. Are you born with it? Well, some people are born with the defects, okay, that lead to hernia. So you may actually see it that it occurs in some families, or especially, let's say, a farming community. Oh, the father is a farmer, he has it. The son has it. All the boys have it, you know. And so you can say that, oh, sometimes it appears that it runs in families, but usually it's because of the kind of activities they are engaged in, and also because they have that predisposition, that they have that weakness, okay, in the muscle wall. So it's not spiritual, but it can actually run in families.
Thank you so much, Dr. Babs. Thank you very much. And so you actually you touched on my next question. So it's good that we even it's helping my flow better. So when you said the fact that some activities can cause it, I remember even Dr. Para mentioned too how lifting heavy things can cause it. I remember that someone told me, I think it was either my driver that mentioned it that period when I was trying to get, when I was trying to understand the whole hernia disease condition and everything. I remember someone saying that it comes with hardship. That was the phrase the person actually used. So Dr. Para, this is actually over to you. Does gymming, extra gymming, those guys that love to gym, those guys that love to lift heavy weights, are they predisposed, more or highly predisposed to hernias? Or is it, does it come with hardship like people think? Is it something that is prevalent with people who do hard labor activities? And then if you find yourself in that kind of situation, how do you prevent, developing hernias? Because if, for instance, you are someone who wants to keep fit and you go to the gym a lot and you do lots of these activities, how do you prevent it such that you don't develop hernias, from doing some of these activities? Farming. Now, farming is an in thing. You're even a farmer, Dr. Oppa. So can you help us? How can we prevent it by still doing some of these activities and then not developing hernias from it?
Okay, thank you. So the prevention of hernias for those people who gym, they have abdominal binders that they wear when they're, especially for the weight lifters, and some other special gear that they wear when they are lifting those weights. That is a form of prevention for those that want to engage in weightlifting. For others who are not engaged in weightlifting and every other form of exercise, the increased tone in the muscle is actually a preventive measure. It's the weakening of these muscles that predisposes to hernias. Now, in special instances, when you have people who, like you mentioned, farmers or people who carry bags of cement and other heavy loads as part of their regular work, it's difficult to prescribe something for them that is going to prevent it. But going off the counter, I would say if they also wore abdominal binders while they are carrying buckets of water, while they are carrying their bags of cement and all that, I think it will also offer some sort of prevention. There is the other aspect too, which we must not neglect. And that is that the hernia is not one factor, especially for those people who are not born with defects. It's not only one factor that predisposes to herniation. So even in farming communities, like Dr. Babs mentioned, you can have a whole family coming with hernias because they have a birth defect that predisposes to herniation. In that same community, you can have people who are farmers who don't have hernias because they don't have that birth defect. So it's a combination of their work and the predisposition. Now, malnutrition also can predispose to hernias in the sense that the muscles tend to weaken out when we lose weight. They become flabby. And also in this class of people who tend to carry weight and exert themselves, one would avoid that. One would counsel them to avoid smoking, to avoid excessive weight gain, and anything that will constipate them. So it's still the basic things that we talked about, but everybody has to x-ray themselves and identify what are my own predisposing factors and deliberately try to eliminate them from their own lives.
All right. Thank you very much, Dr. Oppa. Good one there. A quick one. Thanks so much, Chineye. I would just like to add to like the previous question earlier said, looking at could this be a village thing or whatever? I want to ask, is there any means of traditional therapy that possibly you've come across, or maybe the use of agbo or concussions or things like that, that could be that could suffice as an alternative? Is there anything like that, sir?
Okay, so that's a very valid, very interesting question. We live in an environment where almost every patient that presents to us for a surgical procedure has sought non-surgical options for treatment. Sometimes they'll ask you directly if there's a medicine that you can prescribe for them. Sometimes they will tell you that they've actually been to a place where they were assured that if they take certain things for a long period, that the hernia would resolve on its own. So I can say categorically, both from literature and from my own little experience, that there are very few instances where a hernia will resolve on its own, and it doesn't require any form of agbo or medication. And that is in children below the age of 5 years, specifically umbilical hernias. So if a child is born and has an umbilical hernia before the age of 5, there is the tendency that the defect will reduce gradually, and by the age of 5, that defect should be totally closed. However, if by 5 years old, that defect is not closed, then it is an indication or a reason why it needs to be operated. On the other hand, there hasn't been till date, there are no drugs, no traditional options for the treatment of hernias that exist or are available. The only option for the treatment of a hernia today is surgery.
Wow, that's the only option.
Yes, sir.
Well, we believe in miracles.
Yes, we believe in miracles, but you know, miracles happen when people have applied their faith deliberately. So that may also be a spiritual surgery, sir. If you permit me.
You're very correct. You're very correct.
Yes, sir.
Okay, I think you've answered my next question, but I want to just ask if you can throw more light into, I know there are different types of hernia. So are there those types, or in any of those types, that people can live with all through their lives and won't have to go through surgery?
Okay, so like Dr. Babs mentioned earlier,
Yeah.
if the defect through which the organ is protruding is wide enough,
Okay.
and it doesn't cause symptoms like pain, obstruction, and it doesn't get complicated, anybody can live with their hernia all through their life. The only thing is that it will affect the quality of life. When I mean quality of life, I'm talking about cosmetic appearance. Some people want to have a perfect figure, six-pack and all that. The hernia would interfere with that dream figure. And then in some people, hernias actually reduce their exercise tolerance.
Okay.
These two things are not hard symptoms or signs. When I say hard symptoms, I'm talking about a hard symptom is something like pain or inability to sleep. No, a hernia doesn't cause that kind of thing if it is not problematic. It's just more of a psychological or emotional state, which is it qualifies for intervention, but it's not as emergent as someone that comes with pain. Now, but in some instances, the defect is actually narrow. And the danger is that what protrudes through that defect may not be able to go back as freely as it has protruded. And that is an indication for surgery.
Okay.
Yes.
Okay. All right. Thank you very much, sir. I think I have one more question.
Yes, sir.
So I want to ask that what's like the success rate of those surgeries in different areas where it has been performed? What are the success rates? Like, is it like a 50-50 or 80-20 or whatever?
Okay, so there are many factors that go into quoting of a success rate. I'll just mention them.
Okay.
And then I'll now state the statistics. So the chances of a hernia surgery succeeding are higher in the hands of someone that has done quite a number. And in layman's terms, we'll say an expert.
Yes.
In the hands of an expert, yes, the success rate is higher. Now, the second factor is the type of hernia. If it is a hernia that has been repaired before or a hernia with a wide defect, the success rate is usually a bit lower. Now, having said these two things, in giving an ideal instance, the success rate for hernia surgeries ranges from as high as 90% to 99%.
Wow, 90 to 99%.
Yes, and the problems that the most common problem that we tend to see is recurrence. That's the hernia happening again. So that's the commonest complication. But with the technologies that are evolving now, we've gotten as high as 99% success rate with hernia repairs.
Wow, beautiful, beautiful. Thank you very much, sir. Thank you very much.
You're welcome,
Dr. Babs, are you there, sir? Let me quickly go to Dr. Babs.
I'm here.
Hello, Dr. Babs.
I have one
there?
question.
I'm here.
For Dr. Babs. Yeah, I have a question for Dr. Babs. I think most of us have been talking about. I think we've been talking a lot about the guys and the men here. So let's talk more about female hernias. Let's be gender balanced. Let's talk about female hernias. So what happens? How do I know, or how does one know, a lady know that she has a hernia? You know, I don't think it's common in this part of the world, though, but what if somebody's just suffering in silence? She doesn't even know she has a hernia. What are some of the things she would feel? What are some of the symptoms she would feel? How would she know that it's not, something that is just normal? And at what age would this kind of thing start? And then a child too. How does a mother know that her child might likely be having, a hernia? At what age would she notice it? And what would she notice? I think it's a couple of questions. Can you handle all of that?
Yeah, they're actually very interesting questions. And as you were asking them, a lot of things were coming to my head. But something that I don't want to forget, let me quickly mention this before I go into the women fully. If you have a young girl, especially less than 1 year old, that has a hernia, especially bilateral inguinal hernia, please don't operate it. Take her to a doctor and make sure they do hormonal profile for her. The commonest cause of bilateral inguinal hernia in young girls, less than 5, usually 1 to 2 years, is what we call androgen insensitivity syndrome. And those are the ones that look like females, but they're actually males. So those are the testes in the young boy that does not have a scrotum to land in. So they stay in the inguinal area and appear as bilateral inguinal hernias. Okay, so because you mentioned young girls, that just came to my mind. So if you have a young girl and has bilateral inguinal hernia, a bulge on the two groin areas, please make sure she gets hormonal profile and she gets reviewed by endocrinologists before you do anything. So that said, hernias appear not to be common in women because they usually don't show on the skin. For the men, you can see the hernia in the inguinal area easily, but for women, it doesn't push out. You may even examine and never notice it, but she will continue to have abdominal pain. So a lot of abdominal pain in women are actually caused by hernias, but they are not diagnosed easily. So when you have unresolved abdominal pains, it's good to have a scan. It's good to see a surgeon. A lot of people just go to the chemist or go to medical officers. They just go to the hospital, they have a review, and they are gone. But surgeons are trained because they are used to things like that. So when you see a surgeon and he examines properly, he will go ahead and do a couple of investigations, especially an ultrasound scan, and then you may be able to diagnose hernias. So the reason it appears not to be common in women is because it doesn't hang in the groin like it hangs in men. Okay, I don't know if Dr. Parabi wants to put a surgeon's experience into that.
Yes, sir. Thank you so much for your response. What you said is absolutely right. And even though going by statistics, hernias are not common in women, but there are some specific hernias that are more likely to occur in women than men. And I'll just talk about them. So one of them is pregnancy related. Because pregnancy involves the increase in size of the uterus and it increase in the size of intra-abdominal organs, it tends to protrude through the intra-abdominal organs tend to push through weakened part of the abdominal walls. And so umbilical hernias, a woman may have grown up as a girl not having a hernia, as a young woman not having a hernia, but after the first, second, third, fourth pregnancy, they start having protrusion around the umbilicus. That's usually a hernia. And like you said, sometimes it may not be obvious to the eyes until somebody examines and finds a defect. The second one is an incisional hernia, especially for women that have had abdominal operations, maybe a appendectomy, or even a cesarean section, which is the commonest, or any other surgery around the uterus. During pregnancy, that serves as a weak spot where the abdominal wall a defect can be created, and then the organs can protrude through. So these two kinds of hernias are commoner in females. Then the third one, as women tend to grow older, is a femoral hernia. It's more likely to occur in an elderly woman than in any other age group. And surprisingly, on outreaches, I've seen medical outreaches. That was the first time I saw a femoral hernia. And after that first time, I've seen almost 10, and its classical description, elderly female. There isn't any particular reason why elderly females are predisposed to having femoral hernias. Maybe they've had it all their lives, we don't know. And then it's just when they're in the elderly age group that they tend to notice it, or it starts developing symptoms. Usually it's quiet. It's only the patient that can tell you that I have this swelling. Sometimes to us, the doctors, it's not so obvious, but once you open up, it's there, a femoral hernia. So these are the hernias that are commonest and specific to female populations.
All right, thank you very much, sir.
Thank you, sir. So someone has a question. Yeah.
Yeah, Mayawa Momo, you raised your hand. You have a question? Mayawa Momo, please, you can talk. You can unmute.
Sorry, it was a mistake. I don't have a question.
Okay, all right.
Okay.
Thank you.
So we're looking out in the chat room. There are no questions from any of the audience. It means that all the sessions were well understood, I guess. So if you have any questions, please, you could drop them in the, okay, someone is, okay, I think it was a mistake too. If you have any questions, please drop them in the chat room while we, get, so in the meantime, as well, you have a question? In the meantime, while we're waiting for questions, please, I would like us to appreciate the speakers in our native dialect. I like to do that. So let's do it in a unique way. So wherever you're from, you can say thank you in your native dialect in the chat room. So just say thank you to Dr. Adekunle and Dr. Oppa for this session. It was really enlightening. If we were to go and do Google research and read about it, I doubt people would have been able to get this much information and this well explained. So let's say thank you to them in the chat room in our native dialect. Dalu no saz. So wherever you're from, just say thank you to them in your native. So so in the meantime, we're waiting for your questions, please. If you have any question you would like us to address, please just send it to us in the chat room while we're waiting for our thank yous. Thank you so much, sirs. Can you see all the special thank yous? We really appreciate you, sirs. Thank you so much. Lola, you're raising your hand. Lola, do you have a question?
Yes, I have a question.
Okay, please.
Thank you to the panelists for a very informative session. Okay, so my question is, I think one of the doctors mentioned that more like a retroviral screening has to be done before a hernia surgery. I may not have heard that correctly. I'm just curious as to what the correlation between a retroviral screening and a surgery is. And then secondly, I know that hernia is more like an inflammatory, maybe not inflammatory, but any condition really that is chronic and requires the body to continuously heal itself, usually has a predisposition to cancer. So can hernia conditions in the long run eventually predispose the person, this person who is sick from it to cancer?
Okay, thank you. I believe that question is for me.
Yes, anybody.
Can I go ahead and respond?
Yes, please.
Okay, so first, I'll take your last question. There is no correlation between hernias. There isn't any correlation between hernias and cancers. So a hernia will not lead to cancer. It's not part of the natural history. The worst thing that can happen with a hernia is either it gets complicated by strangulation or intestinal obstruction, or the defect gets so wide that it compromises the patient's exercise tolerance. Now, with regards to retroviral screening, there are a number of reasons why we want to do retroviral screening. First, because people who are retroviral positive and are tending towards the end of the spectrum of that disease, which is HIV, tend to have a compromised immune system. And that means that any wound you create in these individuals has to be specially cared for, otherwise it will get infected. And from getting infected, it can result in prolonged healing and scars that are not palatable and not presentable. The second reason is because surgery brings an additional stress to the immune system. So someone could be existing in their normal state of health, and if we are unaware that this is someone that has retroviral positive, the surgery can be the one to precipitate a downward trend in that normal state of health. And a number of cases have been recognized where a stress factor has precipitated the deterioration of the health condition in a retroviral positive patient. Now, the third reason why we do screen is actually protective for the team and for other patients. You know, a lot of times the instruments that we use to perform hernias are recycled amongst patients. They may not be recycled that day, but after they are used, they are packaged and then they are washed and sterilized for another patient's use on another day. If it has been exposed to a retroviral positive patient, there are special cleaning and sterilizing methods that should be used to make those instruments fit for the next patient. The fourth reason is when we go for outreaches, because our supplies are limited, we like to leave retroviral positive patients for the end of the day so that after they are done, we shut down and we do a proper cleaning. Remember that this is surgery. There will be some blood spilling on the ground, on the table. So all of this has to be properly taken care of before you bring in another patient who is not retroviral positive. So there are many reasons why we do that, but these are just the ones I can remember off head. I think this is now, you may think it's a bit selfish or self-centered, but this is not the last reason. Members of the team are required to have prophylaxis present in the theater if we're operating on a retroviral positive patient, so that in the event that you mistakenly expose yourself by pricking yourself, you don't have to panic. After surgery, you just pick a few of those tablets and you go home with them and take the post-exposure prophylaxis. That's what we call it. Yeah, so these are the reasons why we screen the patients.
Thank you so much, Oppa. That's my
Welcome.
area of specialty, the PEP and the PrEP. So that's why I was really flowing there. Thank you so much. So yes, I think we've come to the end of this beautiful presentation, and we have SB. Are you here for your closing remark? Are you ready for us? We're rounding up. I think I don't know if there's any other question. Let me ask Chris. Does anyone have any other questions? Please, if you do, you can unmute your microphone and speak and ask your questions. In the absence of any other questions, we want to invite Sister Bukola to give the closing remark.
Sorry, Lala Shopeju is still raising a hand, or was it the hand that was raised before?
She sent in one more question, so possibly she still has a question. Hello, Lola Shopeju, are you still there? Hello, Lola Shopeju. Okay, we can hear you. Can you answer? Okay, can you unmute and speak up, or you want to type in your questions? Oh, okay, all right. Send in your question right now. All right, while we're waiting for our question.
Okay, I've been unmuted. Okay, so my final question is PALS the same thing as hernias? I know like PALS is like a part of the body of the rectum pushing out. So is it the same thing? Is it in the hernia spectrum, or is it something completely different?
Okay, so let me address that question. First, let me get a clarity, or explain some clarity. When non-technical terms like pile are used, it's used to describe a number of things, and I want to just list them. It's used to describe hemorrhoids. Hemorrhoids are engorgement of the veins of the anus and the rectum. It's also used to describe anal tags. It can be used to describe the fistula in anal, which is sort of a complication of an abscess. It's used to describe an anal tear, which has occurred either from constipation or those people who, when the receptive gay partner can get an anal tear. So this is what that technical term pile, or that untechnical term pile, has been used to describe. Any condition around the anus is just described as a pile. Now, but what you have described when you explained was a hemorrhoid, which is the engorgement of the veins in the rectum and it's protruding through the anus. That is not in the spectrum of hernias. What happens in a hernia is a normal organ is pushing out through a defect or a hole in the wall of a cavity. What's happening in hemorrhoids is that the normal blood vessels have been distended because of the blood that is pooling there. And then it can actually get complicated by infection. The blood can now change from the normal liquid state to the solid state, which is the blood clot. And we call that a thrombosed hemorrhoid. And it can get ulcerated. All these things can possibly happen, but they're not the same thing. They're totally different disease conditions.
Thank you very much, sir. We're glad you've done a great justice to that. All right, before Sister Bukola comes up, today is 25th of September. Today is known as the World Pharmacist Day. So as a pharmacist, we want to wish all the pharmacists out there worldwide, I want to say happy World Pharmacist Day to all pharmacists in the building and wherever you're connecting with us from. We're saying happy World Pharmacist Day. So we call on SB for the closing remark and to tell us much more about Pistis Foundation and the upcoming Ubomi medical outreach. Thank you, SB. Are you there?
Right. Thank you very much. Okay, I think I personally also have one question I'd like to ask.
All right.
We've been talking about surgery. How does the surgery, does it really last long? How long does it take? Is it just some simple surgery, 1 minute, 2 minutes, 1 hour, 3 hours, 4 hours, just to allay some more fears?
Okay, so in the hand of an expert, a hernia repair can be a very, very simple procedure. And an expert is not somebody who is trained per se, but somebody who is conversant with this procedure. So it can be someone that just graduated, it can be a practitioner of 40 years, but the more you do, the more proficient such a person becomes. Now I want to use myself as an example. The first hernia I did as an individual lasted about 1.5 hours operating time. And the last one I did, I thought that's the first I did as an individual. Now the last one I did was under 15 minutes. This is how good somebody can become over a long period of being proficient. But that's not the only criteria for concluding that the hernia is a simple procedure. The other criteria include the condition of the patient, the condition of the hernia, what materials are available. So it's still not a yes and no response. A hernia surgery can be difficult in the hands of a novice and can be very, very easy in the hands of someone who is proficient. And depending on the materials that are available, if it was in the UK or the US where they have meshes, once that hernia is repaired, you can bet your next 10 years salary that it will never recur. But in a place like Nigeria, when we're doing it in resource controlled environments, maybe like an outreach where we have to manage materials, if someone comes with a terrible hernia, there is the chance that after a few years that the tissues will weaken and then the hernia would recur. So yes, it can be very, very simple in the hands of an expert. And based on that, I wouldn't hesitate to recommend that procedure for anyone that requires it. It can also be done under a variety of anesthetic options. It can be done with the patient awake, it can be done with the patient sleeping, it can be done with regional anesthesia, depending on the patient's choice. So it's a very, very, very safe procedure. Yeah.
All right. Thank you very much, sir. Moderator, is another hand raised.
Modupe Shangosoya, can you please ask your question?
Yes. Good afternoon, everyone. I just feel that I don't have a question, but I just want to chip in this, my experience as a contribution towards allaying the fears of mothers. Because when the hernia is detected at birth, it could be something very panicky for mothers and even the parents entirely. I remember some 47 years ago when I had my first son and he was diagnosed with hernia. I never heard about it in my life before then. So I was so unhappy, so heated up, thinking that what could cause this? What, for heaven's sake, where did this one come from? So that time, what do you call it? The scrotum was so swollen and probably painful. So at 4 months, he had to be operated at the UCH, University Teaching Hospital in Ibadan, and by one of the professors there. But I almost ran mad then, thinking when they took my 4-month-old baby to the theater. And by the time he came out, I simmered and was so prayerful that, God, you have given me this boy. I don't want to lose him. You won't let me lose him. Please keep him from me. And that was exactly what God did. Today, he's a big man, a father himself, and everything is all right. So we give thanks to God. So I want to say that when there is supposed to be a surgery, we should just put everything in God's hand and concede so that we will enjoy better health. Thank you. Oh, Abi, it was not recording. Jay, what is it? Hello? Oh my God, what happened?
Thank you, Ma.
We heard you,
I hear you,
madam.
Thank you, Ma.
Thank you.
All right, thank you. SB, are you ready?
All right, thank you very much. Right, thank you so very much once again. It's been an insightful session for me. Thank you to everyone. And our moderators, our speakers, we say we thank you. Just to add more to what Mr. Stanley already mentioned, Pistis Foundation, as some of us, we already know, a not-for-profit organization, and we are focused in 3 different areas: health, education, and shelter. And of course, this webinar is put together by the health team. And the health team, one of our goals and objectives really is to ensure that we make medical services and all of that accessible to everyone, right? And one of our motto also is to ensure that we are both preventive and curative. And of course, this, as we have today, the webinar is one of the ways in which we put forward the preventive part, of our objective, to ensure that people are aware, of what they can do, as our speakers, they've been able to exhaustively tell us how we can just manage ourselves. And of course, the other part of it also is the curative, the surgery, right? So this then takes us to our flagship program, our flagship outreach, which is called the Ubomi Medical Outreach. The first moderator, Chineye, actually mentioned this while she was introducing Pistis Foundation. And just to add to that, we thought it to be a yearly outreach. However, we had planned and put things together for 2020, and then COVID struck right about where we're about to start the outreach, so we had to postpone. However, for the benefit of everyone here this afternoon, we will be having another outreach, albeit not on that large scale. Chineye mentioned that we target about 3,500 to 5,000 persons. However, this will be on a little low scale, and we are going to be having free surgeries for hernia. Yes, you heard right, for hernia. So this for us is like a teaser telling us that Ubomi Medical Outreach coming soon, precisely in the next month. Let's all be on the lookout, and let's tell as many people as we know that may be suffering from this ailment to be on the lookout and just follow us on our various media pages to get this information. And we trust that as many as come into that outreach, come next month, will certainly be healed completely. Amen. Thank you so very much, moderators. Over to you.
Well, thank you so much, SB. Sister Bukola, that's great. I was just typing that, can we all put hands together for Pistis Foundation? I mean, this is great. So there's going to be free surgeries for people who are down with hernia by next month. Ubomi Medical Outreach will be coming up. And I want us to use this privilege to reach out to everyone whom we know could benefit from this, whoever is suffering from hernia and possibly has been challenged one way or the other with the cost of treatment and all of that. I believe this is a great privilege. This is an opportunity. And Pistis Foundation is doing this again. They've done this before. I really don't have the figures, but then a lot of people were treated. I mean, this surgery was done for quite a number of people. And yet again, Pistis Foundation is still here, standing strong and ready to, give this opportunity to a lot of people out there who are down with hernia and possibly are challenged with pain for the surgery. Let's put hands together for Pistis Foundation. This is a great one. And also let's take it upon ourselves to reach out to anyone, anywhere. Let's spread the news. I believe all the advertorials will be out very soon for us to share, and let's invite as many people as much as we can to just come and be part of the Ubomi Medical Outreach. A lot of people benefited from it. So I'm sure so much is going to be going on, and I think you should watch this space. Please like our pages, our Instagram page, I think Pistis FDN on Instagram, Pistis FDN on Facebook as well, and also Pistis Foundation on YouTube. Please, let's reach out for more information. Please reach out to Pistis Foundation on all of those channels so that a lot of people can benefit from the opportunity coming up. We'll be glad to be a channel of blessing to a lot of people out there. So please, thank you very much, ladies and gentlemen. It's been an awesome time. I believe you agree with me. And I want us to also say thank you to our speakers today, Dr. Oppa, Dr. Babs. We really, really appreciate you. We don't take this privilege for granted. We are really grateful for you sharing your time with us today. It's an amazing and awesome time. I can imagine, I can testify. Thank you so much. In the comment section, please let us say thank you to our speakers for today. We are really very, very grateful. Thank you so much, Dr. Babs, Dr. Oppa. We want to really, really say a very big thank you to you, a very big one. Thank you so much. And to all of our audience, for those who are connected to us on Facebook Live, we want to really, really share a very warm welcome to you. We want to say thank you for joining us today. Thank you for being part of this month's webinar. We are really grateful and we thank God for you. We believe that everything shared today would be of great insight to you to be able to help and share the messages and the insight today with everyone that you know will benefit from this. We're going out there and we're also going to be light to everyone who will need this information. Thank you so much for joining. Thank you for your time. We don't take it for granted. We are really, really very grateful. We are going to be shutting down on this. It's been an awesome time together. We want to say a very big thank you once more. And I'll call on SB. I hope you are still there, Sister Bukola Odunlami. I believe you are still there so we can have a closing prayer. If there's anything we still have to share, we want to say, we can still share quickly. SB, hope you are there. Sister Bukola Odunlami, thank you so much. So we will take the closing prayer right now.
Thank you very much.
You're welcome, ma.
Let us pray. Father divine, we give you thanks. We are grateful for your faithfulness. We are grateful for this event. Thank you for using your doctors. Thank you for using the moderators. Thank you for the lives of everyone that logged on. We thank you, Father, because your will be done in everyone's lives. We thank you, Father, because this is the beginning of healing upon every life. Thank you, Father, for the success. We give turn all the glory to you in Jesus' name. Amen. Thank you very much and have a great evening.
Amen. Thank you very much.
Thank you.
All right, ladies and gentlemen, we look forward to the next session, the next webinar, which will be coming up very soon. So we'd like you to look forward to it. We'll share as much as possible. Thank you very much.
Thank you.
Thank you, Dr. Babs.
Thank you, Dr. Babs. Thank you, Dr.
Thank you, Dr. Oppa.
Thank you.
So much.
Thank you,
We're really
Stanley.
grateful.
Thank you, Chineye. Thank you, everyone.
All right.
Thank you. It was a great pleasure.
Thank you,
you.
sir.